There is a conversation that happens in urology offices across America every single day, and it follows a remarkably consistent script. A man over 60, usually having dealt with the problem for 1, 2, sometimes 3 years before finally coming in, sits down and describes the same thing. His urine stream is weaker than it used to be. It takes longer to get started. The flow is slower. Sometimes it stops and starts. Sometimes he feels like he is not fully emptied when he finishes. His previous physician, if he mentioned it at all, told him it was probably his prostate, and either prescribed an alpha blocker or told him to watch and wait. And for many of these men, the alpha blocker provided some improvement, but not complete resolution, because the prostate is one cause of a weak stream, not the only cause, and in many cases not even the primary cause. I am Dr. James Whitaker, board-certified urologist, and in this video, I am going to walk you through the 4 principal causes of a weakening urine stream in men over 60, explain the specific mechanism behind each one, and give you a clear framework for understanding which of these causes may be driving your specific symptom pattern. Because the treatment for each cause is entirely different, and treating the wrong cause produces the frustrating situation that so many of my new patients arrive with. Years on medication with only partial benefit. Lawrence was 64 years old when he came to see me. He had been on tamsulosin, an alpha blocker, for 2 years, prescribed by his primary care physician for what had been assumed to be BPH-related urinary obstruction. The tamsulosin had helped somewhat in the first 6 months, but his stream had continued to weaken over the following 18 months despite medication compliance. His primary care physician had recently doubled his dose with minimal additional effect. When Lawrence came to my office, I performed a comprehensive urological evaluation, including uroflowmetry, a test that measures the speed and volume of urine flow objectively, a post-void residual ultrasound to measure how much urine remained in the bladder after voiding, a digital rectal examination, a PSA blood test, and a detailed history of his symptoms. What I found was not what his previous physician had assumed. Lawrence's prostate was moderately enlarged, a 35-gram gland, which is notable but not dramatically enlarged. But his uroflowmetry showed a specific flow pattern, a prolonged plateau-shaped flow curve without the normal bell-shaped peak that indicated a problem not at the level of the prostate, but at the level of the detrusor muscle itself. Lawrence's bladder muscle was weak, and no amount of alpha blocker, which relaxes prostate and bladder neck smooth muscle to reduce outflow resistance, would improve a stream that was limited by the force of the pump rather than the size of the opening. This brings me to the first cause of a weakening urine stream that is consistently under-recognized: detrusor underactivity. The detrusor is the smooth muscle that forms the wall of the bladder. Its contraction generates the voiding pressure that drives urine through the urethra during urination. After the age of 60, the detrusor undergoes histological changes, progressive fibrosis, loss of smooth muscle cells, and replacement with connective tissue that reduce its contractile force. A bladder with a weakened fibrotic detrusor cannot generate the intravesical pressure needed for a strong urinary stream, regardless of whether the outflow tract is obstructed. Detrusor underactivity is present in an estimated 40% of men over 70 with lower urinary tract symptoms, and it coexists with BPH in a substantial proportion of these men. When a man has both BPH and detrusor underactivity, which is common, treating the BPH alone with medication or even surgery may produce very little improvement in stream strength because the limiting factor is the pump, not the pipe. The diagnosis of detrusor underactivity requires urodynamic testing, a specialized study that measures bladder pressure during filling and voiding simultaneously, and the management focuses on bladder training, timed voiding protocols, and in some cases, assisted emptying strategies rather than the standard BPH medications. The second cause is urethral stricture, a narrowing of the urethra caused by scar tissue that forms in response to prior inflammation, infection, trauma, or instrumentation. Urethral strictures produce a characteristic uroflowmetry pattern, a low, flat, prolonged flow curve with reduced maximum flow rate and reduced average flow rate, often with a prolonged voiding time. They are distinct from BPH-related obstruction in that the narrowing is typically in the anterior urethra, the portion that runs through the penis, rather than at the level of the prostate. Risk factors for urethral stricture include prior urinary tract infections, sexually transmitted infections, particularly gonorrhea, prior urological procedures including catheterization or cystoscopy, and pelvic trauma. Men who have had prior urological instrumentation and who notice a progressively weakening stream should specifically discuss urethral stricture with their urologist and request uroflowmetry and potentially urethroplasty, an imaging study that visualizes the urethra directly. Treatment for stricture is different from treatment for BPH. It may involve urethral dilation, direct vision internal urethrotomy, or urethroplasty, depending on the length and location of the narrowing. The third cause is bladder neck contracture, a specific form of obstruction at the internal urethral sphincter, the smooth muscle ring at the bladder outlet that controls the initial release of urine. Bladder neck contracture can occur as a complication of prior prostate surgery, including TURP and radical prostatectomy, or as a primary condition in men with significant scarring from recurrent prostatitis. It produces a very similar symptom profile to BPH, but does not respond to the same medications because the obstruction is from scar tissue rather than from smooth muscle tone or glandular enlargement. Men who have had prior prostate surgery and develop or redevelop a weak stream years after the procedure should specifically be evaluated for bladder neck contracture rather than simply assuming BPH recurrence. The fourth cause, and the one that surprises most of my patients, is impaired neurological control of voiding, secondary to diabetes-related peripheral neuropathy. The detrusor muscle is controlled by the parasympathetic nervous system through the pelvic nerve, and the voiding reflex requires intact sensory nerves that detect bladder fullness and motor nerves that coordinate the detrusor contraction during voiding. Diabetic autonomic neuropathy, damage to the autonomic nerves caused by chronic hyperglycemia, progressively impairs both the sensory detection of bladder fullness and the motor coordination of detrusor contraction. The result is a bladder that fills to large volumes without generating a strong urgency sensation, that requires prolonged straining to initiate voiding, and that produces a weak, interrupted stream. The diagnosis of diabetic cystopathy, the bladder dysfunction caused by diabetic neuropathy, is often delayed because the symptoms overlap closely with BPH, and men with diabetes who develop lower urinary tract symptoms are frequently assumed to have BPH without neurological testing. Any man with diabetes of more than 10 years duration who develops lower urinary tract symptoms should have a post-void residual ultrasound to check for significant urinary retention, which is the most dangerous complication of diabetic cystopathy and can silently damage the kidneys through back pressure if undetected. What does this mean practically for you? If you have been on BPH medication for more than 6 months and your stream has not meaningfully improved, or if your stream continues to weaken despite medication compliance, I strongly recommend requesting formal uroflowmetry, not just a symptom questionnaire, but an objective measurement of your flow rate and pattern. A maximum flow rate below 10 milliliters per second is clinically significant obstruction. A flow curve shape that does not show the normal bell-shaped peak suggests a specific underlying cause that will direct the treatment. A post-void residual above 200 milliliters requires urgent attention. These objective measurements, combined with a detailed history and examination, allow your urologist to identify which of the 4 mechanisms I have described is driving your symptom and prescribe the correct treatment rather than the default treatment. Lawrence ultimately underwent urodynamic testing that confirmed impaired detrusor contractility combined with moderate BPH-related obstruction. His treatment plan, which combined a minimally invasive urolift procedure to relieve the prostatic obstruction with a bladder training and timed voiding protocol to optimize the residual detrusor function, produced a significantly better result than continued medication had achieved. His stream is not what it was at 35, but it is functional, it is consistent, and he is no longer spending 15 minutes in the bathroom waiting for a void that takes forever to complete. Your urine stream is a window into your lower urinary tract health. Changes in stream strength, speed, continuity, and completeness are not things to dismiss or accept as inevitable. They are symptoms with specific causes and specific solutions. Get evaluated, get measured, and get the treatment that addresses what is actually happening, not just what is most commonly assumed. Share this video with every man in your life who has noticed urinary changes. Leave a comment below describing your stream changes and when they started. Like and subscribe for weekly urology content. I will see you in the next video.